Hi, this is Elliot Fishman, and welcome to May 2026. I have 10 excellent cases to share with you, and without further ado, let's get started. The most likely diagnosis in this 30-ish-year-old male is, well, what do we see? We see a cystic mass in the left paraortic region. Now, it could be necrotic nodes. It could be lymphoma. Lymphoma usually isn't so cystic unless it's been treated. So that indeed is a possibility, but this patient, I'll tell you, has had no treatment. We do see low-density nodes in tuberculosis. We do see low-density nodes in Whipple's disease. Sarcoid nodes are typically soft tissue density and are not going to be cystic. But in a male, you have to think about a germ cell tumor. Germ cell tumors arising in the testes typically will spread to the paraortic regions. So again, treated lymphoma would be a consideration. TB, couldn't exclude it, but germ cell tumor was the correct diagnosis. The most likely diagnosis in this case, well, what do we see? We see a mass in the chest wall. It involves the lower portion of the sternum. It's retrosternal and it's presternal. I don't see a lot else on the study, the esophagus. Maybe there's a hiatal hernia. This is not the look of small cell lung cancer because I don't see a lung mass. Yes, you can get metastasis to the chest wall, but it's not the typical look. It's not likely osteomyelitis. I can't exclude that, but you don't see a lot of bony destruction. Germ cell tumor is typically going to be an anterior mediastinal mass, sometimes posterior mediastinum, but not in the chest wall like that. If you said something like a Ewing sarcoma or a sarcoma involving or beginning in rib or costal cartilage, I would consider that. But when you see a mass that involves the chest wall, both anterior and posterior to bone, and it has the really classic soft tissue appearance on the sagittal view, you got to be thinking about lymphoma. And this case was a good example of follicular cell lymphoma. The most likely diagnosis in this case, well, what you see is diffuse thickening of the left breast, minimally, but really thickening of the right breast. You see the skin thickening, you see some nodules in the chest wall. There's several nodules present. The patient also has bilateral pleural effusions. So you know the focus is really in the right breast. Lymphoma can involve the breast with marked wall thickening and tumor infiltration, so I couldn't 100% exclude it, but I don't see any adenopathy in the mediastinum, so it's less likely. This is not the look of a breast abscess. Melanoma can metastasize anywhere, but to be really isolated to the breast for the most part, or its central portion, it would be the breast, and nothing else would be very unlikely. This is more likely to be breast cancer with skin thickening, multiple nodules in the right breast, including in the chest wall, and then malignant pleural effusions. So the answer was B, breast cancer. The least likely explanations for the CT findings are, so remember, least likely. What do I see? I see infiltration of the peri and pararenal spaces bilaterally. I see encasement of the paraortic regions. I see extension going up along the aorta into the chest. Erdheim-Chester can do this. It involves the aorta and peri and pararenal spaces. Extramedullary hematopoiesis most likely involves the perirenal space, but it can involve the paraortic region. That would be a bit less common. Lymphoma can involve peri and pararenal and extend upward. It's not the greatest example for lymphoma, but it's a possibility. But the least likely, so again, it's all relative, is acute pyelonephritis. Pyelonephritis, you can get perirenal space involvement, but not to this extent. You're not going to see the changes going up and down the aorta. This, in fact, was Erdheim-Chester disease, but the least likely diagnosis was acute pyelonephritis. The most likely diagnosis in this patient Well, what you see is a really interesting case. Diffuse thickening of the pericardium and nodular. I got to be thinking about malignancy. And again, lymphoma probably is what you're going to think about. Angiosarcoma can involve the pericardium, but then there's usually a secondary mass involving a primary cardiac chamber like the right atrium. You also see bilateral adrenal masses. So now you say, I have bilateral adrenal masses and pericardial involvement. It's not really a good look for lung cancer because I don't see a lung mass. Well, maybe it's in the upper lung zones. Lung cancer can involve the pericardium, but usually not this bulky appearance. And of course, lung cancer can easily metastasize to the adrenal glands. Melanoma is always something you consider, though pericardial involvement is less frequent. This does not have the look of primary adrenal carcinoma. That can be unilateral usually, but it's not going to involve the pericardium. The most likely and the correct diagnosis in this case, this was B-cell lymphoma involving the pericardium, infiltrating by the cardiac chambers posteriorly, and also with bilateral adrenal masses. A really nice case. The most likely diagnosis in this case, well, if you look in the pelvis, the bladder looks like there are multiple masses in the bladder wall. The first thing I would say is multifocal bladder cancer. Then you look at the kidneys. Left kidney enhances normally. The right kidney looks like it's infiltrated. So now you say I have infiltration of the kidney, multiple lesions in the bladder, clear cell, papillary, renal cell. Those both could explain in theory the renal mass, but not the bladder. Lymphoma gives bulky masses involving the kidney, and usually the bladder secondarily, not primarily. This is classic for multifocal transitional cell carcinoma, which is multifocal in greater than 40% of cases, and in this case arose in both the bladder and extended upward into the ureter and into the right kidney. The most likely diagnosis in this 50-ish-year-old is, well, I see a mass involving the head, body, and tail of the pancreas. It's mainly in the body and tail, but the whole gland is involved, and there's really extensive calcification. Now, mucinous cystic neoplasm is usually more cystic, has septations. Obviously, it can have solid components when it's malignant, but it's almost too solid, too extensive, and typically when it has calcification, it's in the periphery. Islet cell tumors can have dystrophic calcifications, but it's almost like too much infiltration for a neuroendocrine tumor, but it's a thought. It doesn't have the look of an adenocarcinoma. Adenocarcinomas do not calcify typically unless the patient had prior pancreatitis, and typically with adenocarcinoma you would see a dilated pancreatic duct. On the other hand, serous cystadenomas can be large. They can be aggressive looking. They're always benign, but they can be aggressive looking. And dystrophic calcifications, particularly coarse central calcification, as nicely shown in the MIP imaging, is something commonly shown in serous cystadenoma, and the best diagnosis in this case was serous cystadenoma. The most likely diagnosis in this patient with chest pain, well, when you look at these cardiac images, you see a mass that arises from or involves the patient's right coronary artery. Now, angiosarcomas commonly involve the right atrium, but you see mass effect. It looks like whatever's there is involving the right coronary artery, but I couldn't rule out an angiosarcoma. Lymphoma usually also involves chambers of pericardium and would displace the vessel. Vasculitis, Kawasaki's, will give thickening of the vessel, but not this mass-like effect. And when you look at this, it's so nicely round. Now, it would be, of course, helpful to have all of the images of the entire case, but the most likely diagnosis for this case is a right coronary artery aneurysm. They can be large. They can be asymptomatic and incidental findings. Just a really nice example. In this patient with weight loss, the most likely diagnosis, the key findings are multiple solid lesions in the spleen. The spleen is not enlarged. The kidneys look okay. The adrenals look okay. The liver looks okay. It could be melanoma. It could be sarcoid. Sarcoid gives a little bit lower density lesions. They can be small or large. Angiosarcoma of the spleen is an aggressive malignancy, but it's typically very vascular. When I see a spleen that's not necessarily enlarged, but has multiple solid masses, my favorite diagnosis is lymphoma. But if you said to me this was melanoma, I couldn't argue. And in theory, I could not totally exclude sarcoidosis. A very, very nice case. In this patient with back pain, the most likely diagnosis is, well, what you see is diffuse encasement and narrowing of the aorta down through the iliac vessels. It's a pattern consistent with a vasculitis type process, perhaps. Lymphoma can also cause narrowing, but you don't see the bulky adenopathy you typically expect. This is not a recent bleed. And although vasculitis is a consideration, we have to be really large vessel disease. Most vasculitis also would involve the SMA, maybe the celiac, hepatic, splenic, SMA. The most likely diagnosis in this patient is retroperitoneal fibrosis. I would surely consider other possibilities, IG4 disease, which is a form of vasculitis. So if you said vasculitis, I will give you 75% credit. The correct diagnosis was idiopathic retroperitoneal fibrosis. Well, those are 10 cases. I hope you got them all right. I hope you found them interesting. And most importantly, I hope we were able to share some knowledge with you. And with that, I wish you a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.